guess the analogy is, you're on a plane. We all want to have a nice flight and a good experience, but you want the pilot to land the plane. You want the
That's
pilot
a great
to
analogy.
be there for turbulence. And GPs are the ones who have the training to do that in the health system, in primary care. And yes, when we all work together and utilise all of our skills together, we get good outcomes.
Hello and welcome to another episode of Be an Awesome GP. Today we are just stoked to be sitting down with Dr. Nicole Higgins, the President of the Royal Australian College of General Practitioners. I'm recording here on the traditional lands of the Gamagal people, and I pay my respects to elders past, present and emerging. So normally here on Be an Awesome GP we talk about positive topics and promote positivity in general practice, but today we are here to talk about a matter of some concern for GPs, the Unleashing the Potential of Our Health Workforce Scope of Practice Review, Issues Paper 2. Dr. Higgins, welcome to the show.
Hello, Chris. And yes, it's a pleasure to be sitting here talking about the topic today. And as somebody who loves general practice and loves being a GP, for me, I want to make sure that I leave the RACGP and the college in a better place, as we do when I leave. But there are some things that are on our horizon, and scope of practice is one of them.
So for those who might have just had their head to the grindstone doing everyday general practice in their clinic, can you just give us a brief idea of what the scope of practice review is, how it's meant to unleash primary healthcare workforce, and where we're at in the process?
Yeah, so in 2022, the Strengthening Medicare Taskforce was held by the new government at the time, and Minister Butler's our current health minister. Now, one of the recommendations out of the Strengthening Medicare Taskforce was looking at scope of practice of all primary healthcare providers, so GPs, nurses, allied health, and pharmacists as well. Now, there are currently about 14 different reviews that have come out of the Strengthening Medicare, so it's a really, really busy time, but scope of practice is probably the one that's going to have the biggest impact. So part of it is looking at what GPs can do, so what's within our scope, and what other health professionals. So the difference is GPs, we're trained. We do 10 to 11 years of training to become a specialist GP. So we've actually already got the skills within our scope. And often it's the legislation and the regulations that actually hold us back from doing what we can do. There are opportunities such as looking at so being able to diagnose, prescribe for ADHD, for example, being able to manage acne and prescribe Roaccutane, being able to develop those skills that we use as rural generalists. The thing is, it's really focusing probably more on other health professionals, and that is the challenge, and making sure that we all work together in teams, which is the direction of Strengthening Medicare.
And I think, look, a lot of our members would agree with some of the options that are proposed in the reform framework. The streamlining of the poisons regulations to allow better access for ADHD is certainly one that our members would be keen to see streamlining between the states. The concern around some of the scope of practice, duplication and increased cost of the healthcare system, the consumer and the taxpayer is all of some concern for everyone. We've just had Issues Paper 2. What can our members who are interested and keen and want to help implement and advocate for change do at this stage? Where is the next step in the process?
So the first part is actually saying what we want and what has been recommended. So that is multidisciplinary care teams working in general practice and supported by the GP. Now, the Strengthening Medicare Taskforce paper says GP-led. When we work together as teams, we know we get the best outcomes. We know that we keep people out of hospital. The biggest risk, though, with some of these changes that are designed to improve access, is trading off quality and safety for access, and having drilled down to task substitution. we know that all of the different health professionals have different levels of training. Said there's between 16 and 20,000 hours to be a GP. Nurse practitioners between 3 to 5,000 hours. And we're all trained in different ways of thinking and doing, and substituting different roles for tasks is going to be potentially problematic, because there's also the call for equal pay for equal work. And there's two pieces, as you said, you mentioned the Poisons Law before, but also the Health Insurance Act being reviewed to actually address that. The other, my biggest concern really is around fragmentation of care. So we now have, instead of having teams working in general practice, with the change in legislation recently with the collaborative arrangements with nurse practitioners, we're now setting up a competitive model. So, and potentially a two-tiered system where we've got general practice on one level and then another with nurse practitioners, and not working together, but working independently and in competition. And that's never good for patients.
And I did read in your Friday Facts, you were talking about the fact that the nurse practitioner consultation is not held to the 12-month requirement that GPs are for telehealth recently.
Yeah,
very
so
interesting.
well, I think it's an oversight that when they looked at the rules, they didn't appreciate the differences. But what it's now enabled is that nurse practitioners aren't required to have the 12-month relationship to be able to access the MBS for telehealth, whereas GPs do. So we need to make sure that there is a level playing field. And accreditation is also another emerging issue around this out of scope.
And I think one of the areas of frustration from a lot of members, what I'm hearing, is that despite the extensive training, which is really is a crucible medical training, all those hours, giving up time with family, friends, delaying entry into the housing market maybe because of 6 years of study and limited income. Despite all that, despite overwhelming evidence in multiple studies, including a recent one by Baker et al. In British Journal of General Practice about longevity being tied to quality general practice, despite all of that, the direction of the reform seems to be heading away from where we want it to be, which is GP-led care, which is ensuring that the GP is the primary point of contact for primary care.
And that's what we need to be fighting for, is that we're I guess the analogy is, you're on a plane, we all want to have a nice flight and a good experience, but you want the pilot to land the plane. You want the pilot to be there for turbulence, and GPs are the ones who have the training to do that in the health system in primary care. And yes, when we all work together and utilise all of our skills together, we get good outcomes. Unfortunately, the reviewers with scope and also the deputy secretary are a bit enamoured with the NHS. I was at a meeting, and one of the decision makers goes, "Oh, it's fantastic. I've just come back from the NHS. And if you're a GP, you only have to see your patients 15% of the time." Now, that was like a red flag to a bull, wasn't it? We know what we don't want, and we don't want the basket case that's become the NHS. And we're now seeing refugee GPs from the NHS. And, I'm having discussions with Canada. So Alberta, for example, where they're looking towards our health system to improve theirs, and yet we're looking at theirs. So there's always some good things that we can always learn from each other. But we've got one of the best health systems in the world. We're in the top 3. The problem is general practice has been neglected and underfunded for the last 10 years. And, we really need to shore up those foundations.
I think that's a really key point, that this issues paper has talked about how we allocate funding and who we pay for what. And the reality is that healthcare isn't a finite pool of money. And we've been advocating for general practice-led efficient care for some time. And we were really excited about all the extra funding that came in last year, but there's still more to do. People are under cost of living crisis. And it really is worth thinking about for both our members and for anyone else listening, how we spend that money and whether it delivers bang for buck. I guess there's a lot in this report, like don't get me wrong, there's a lot in this report that our members might want to go through, and the RACGP issues paper response is very, very good at summarising that. For those members who are motivated and keen and they want to take action and be empowered, what would you suggest be their first port of contact? Do you want them talking to their local RACGP member? Do they want them talking to their federal member? How would you suggest any further action?
So one of the things we need to do is all of us need to make friends with our local MPs. And what I hear frequently from MPs when I'm in Canberra is they don't see their local doctors, they don't see their local GPs. They see their pharmacists all the time, weekly, for many of them, and they're very organised. So we're in the process of getting that network up. But invite your local MP to your practice. Show them how general practice works. Show them what you do. Because the thing is, people don't understand, like they know what a GP is, sort of, but they don't understand who we are, what we do, and how we work. So that's the first protocol. The other part is why we need to make sure that we continue to work collaboratively and keep our patients in general practice.
Thank you, Dr. Higgins. There's a lot, if people want to review further, the RACG page has some useful links to both the executive summary and the Australian Institute of Health Workforce papers. I think it is a bit of a slog. A lot of us are down in just seeing patient after patient in clinic because we're very busy, but it is a really important issue, and it's an issue where ultimately the patient will be the person who suffers if there's a poor outcome. I will let you go. I know you're off having some family time, and I do appreciate your time this morning. I will pop out and check on my 3-month-old. I think that's good to see two family doctors with families having a good Saturday. Is there anything else you want to leave our listeners with?
Look, Chris, I'm a very normal, ordinary GP working in a regional area who just happens to be doing quite an extraordinary job at this present time. And there is so much that happens behind the scenes, but the best advocates are us. And it's talking to our patients, talking to our MPs. Anyone can reach out to me at president@racgp.org.au. And I think we just need to keep, having this conversation.
Thank you, Dr. Higgins. We do appreciate all the unseen work that goes on behind the scenes. And you are an awesome GP. To our listeners, remember you are an awesome GP, and there's always a good time for advocacy.
Thanks, Chris. Cheers.
Being an awesome GP is not specific medical advice, and the opinions are those of the presenter and guests, not necessarily any affiliated organisations. It is targeted at GPs in the Australian setting, and any local clinical guidelines should be reviewed before making clinical decisions. It is not specific medical advice.